All right, good afternoon, everyone. My name's Evelyn Matongo from CIDES. I will be presenting on the directly observed therapy for ART in children to attenuate viral suppression. So, as we may all know, viral load suppression in children has actually remained a challenge as compared to the adult population. So we have also tried various interventions in order to improve adherence for children. For example, we've tried support groups, we've tried adherence counseling, medication reminders, caregiver support groups, to mention but a few. So in order to curb this challenge, we implemented the DOT strategy so that we can improve adherence for children. Okay, so how did we do this? So we designed SOPs, we also designed orientation packages, we had data collection tools, we had logistics like talk time, we bought phones for the community volunteers, and we also oriented the community volunteers and healthcare workers at the facility on how to go about the strategy. We also had community sensitization done to caregivers as well as other members of the community. We also engaged the neighborhood health committee in order to support the intervention. So we also paired community volunteers with patients, that is the children, that are on ART with unsuppressed viral load for over 1,000 copies. So we also ensured that home visits were done to these children that were in the, sorry about that. So we also ensured that the home visits were done in order to ensure that the children are actually taking the medication as they are supposed to take the medication. So we also ensured that enhanced adherence counseling was offered to the caregivers that are taking care of the children with unsuppressed viral load. As we may know, we are all in this pandemic, so we ensured that the COVID-19 rules were observed. So that is the result there, the results section. So in this intervention, we enrolled about 281 children that had unsuppressed viral load of over 1,000 copies. And we had 281 that were unsuppressed. And then we enrolled 280 children from the 281 in the program. We had 65 children that completed ESC and repeated the viral load at 3 months. Then we had, from this, we had 156 children that suppressed the viral load. So 9 children did not suppress the viral load due to challenges like treatment failure and so on. And then the 115 were still undergoing enhanced adherence counseling at the time of reporting. I must also mention that we did this we employed the intervention in 4 districts of Zambia. That was Kaoma, Chongwe, Lusaka, and Fiwe district. Okay, so from these we can tell that this intervention can actually help the children that have, unsuppressed viral load to attain good adherence. Thank you. For more information, please visit my poster number 24. Thank you.
Okay, once again, this is Ackim. I will take you through an abstract titled Leaving No One Behind. We are looking at the impact of kindergarten ART clinic on HIV treatment outcomes among children enrolled in this program at Lighthouse HIV care facilities. So we are all aware that children are struggling to achieve optimal HIV treatment outcomes, and in particular, viral suppression. When you compare with adults, viral suppression rate in children is very low, and this is evident even in Malawi. When you look at the age of 0 to 5, the suppression rate is very low. This actually poses a significant threat to attainment of 95 treatment targets among this population. As such, Lighthouse, which is one of implementing partners in Malawi, devised an intervention called Kindergarten ART program to address the gap. So this is actually a family-centered DSD model aimed at achieving 3 or 4 things. 1, improving viral suppression. 2, addressing mortality and morbidity. 3, addressing retention issues which are affecting this population. So that's just a snapshot of the battery of the services that we provide in this program. That picture depicts children praying during one of the clinic days, which is called kindergarten clinic. So in summary, we provide a number of services which includes client-centered counseling, psychosocial counseling, even the moms, the parents share experiences and success stories during the clinic, and we also provide educational activities, as we can see on the slide. So what was the objective? Mainly, we wanted to assess the impact of this program on 3 critical outcomes, namely retention, viral suppression, and mortality. Yeah. So on methodology, this was a retrospective cohort study. It was done in 4 settings. These are HIV care facilities. We look at children aged 0 to 5 years. The period ranged from November 2020 to 2021. Those were measured outcomes. For the sake of time, in terms of the finding, when we look at the caregiver relationship status, majority of the caregivers were biological parents, and the majority of them were HIV infected. So in terms of the results, each and every facility managed to enroll at least 80% of these kids. And when you look at the viral load, you can appreciate significant improvement across all the 4 facilities, from as low as 23% to 91% at one particular facility. But overall, the viral suppression improved from 34% to 78% over a period of 9 to 13 months of follow-up. When we dive in and look at the actual viral suppression, and when we pair with the parents, you can appreciate that more than 50% of the children who were suppressed, their parents who were positive were also suppressed. So those were limitations because of time. In conclusion, what can we say? We can confidently say that this program, as a family DSD for children, has the potential to improve viral suppression, including other important treatment outcomes. And we can recommend this program to be scaled up or adopted in healthcare facilities, especially high-volume facilities in resource-limited settings. Thanks for listening.
Thank you.
Good afternoon, everyone. My name is Talitha Crowley. I'm a professional nurse working at the School of Nursing, the Faculty of Community Health Sciences at the University of the Western Cape in Cape Town, South Africa. I'll be presenting on the development of a self-management intervention for adolescents who live with HIV. Sorry, my slides are jumping. So we all know that adolescents living with HIV have poorer outcomes compared to adults. Self-management is a concept that we often use in chronic disease management, but not so often with HIV, and particularly with adolescents. But it entails the tasks that an individual have to undertake to take care of their health on a daily basis to ensure their well-being and improve their health outcomes. We couldn't find any intervention for self-management intervention for adolescents living with HIV in the South African context, and also not in the African context. So we developed this intervention for adolescents aged 15 to 19 because this is the stage where they also transition to adult care and where they need to learn these skills. We use intervention mapping because it's an evidence-based, theory-based approach to developing interventions. This first and second step entails doing a needs analysis and creating a logic model of change. And this was informed by a series of qualitative and quantitative research studies, including a systematic review on self-management interventions for adolescents living with HIV. And if you follow the model, you can see that we have primary change objectives, for example, improving self-management skills, and secondary change objectives, for example, healthcare worker support and family support improvement. And then this eventually leads to behavioral outcomes and health outcomes, such as improved quality of life. This led to a 12-week program with 3 components. There's individual activities that's completed in a workbook, and this is being translated onto a smartphone application, 3 coaching sessions, and 5 peer-led groups that's led by older peers. And we developed these behavior change methods based on self-management components and identified particular practical strategies. We then also consulted with local and international experts, and we conducted focus groups with adolescents living with HIV as well as healthcare workers to look at the validity and relevancy of this intervention. And we got very good feedback, but we do have to consider the human resource implications for the coaching sessions. So this intervention is evidence-based and theory-based, but now we have to implement it for feasibility, acceptability, and preliminary effectiveness. And you're welcome to come and speak to me about this at my poster.
Bonsoir. Je m'appelle Maimouna Diop. Je représente le Centre régional de recherche et de formation à la prise en charge clinique de l'hôpital Fann de Dakar au Sénégal. Je vais vous parler de l'entrée dans la sexualité pour les adolescentes séropositives au Sénégal, entre normes sociales et VIH. Pour le contexte, la sexualité hors mariage reste socialement réprouvée au Sénégal en 2022. Donc l'entrée dans la sexualité des adolescentes, notamment celles vivant avec le VIH, reste donc un défi, surtout en zone rurale. Une étude menée en 2020, dans le cadre du projet IT-VIH, une approche anthropologique de l'échec thérapeutique chez les enfants et adolescents vivant avec le VIH au Sénégal, en contexte décentralisé, a exploré le vécu et la gestion de la sexualité des adolescentes VIH+, vivant hors de Dakar. Pour la méthode, une enquête qualitative a été réalisée en 2020 dans 4 hôpitaux régionaux et 10 centres de santé de 11 régions du pays où sont suivis environ 350 enfants. Des observations et des entretiens ont été menés avec 85 enfants et adolescents, 92 parents tuteurs et 47 acteurs de santé. Alors, comme résultat, les adolescents font face à différentes contraintes. Des contraintes sociales, des contraintes liées au VIH et la réponse des acteurs de la prise en charge. Pour les contraintes sociales, il y a les normes sociales qui exigent la virginité des jeunes filles au mariage. Donc, les parents feignent d'ignorer la sexualité des adolescents. Les mères redoutent des grossesses hors mariage dont la faute leur sera attribuée, et les soignants sont réticents à parler sexualité et à proposer une contraception aux adolescents. Pour les contraintes liées au VIH, la première est en lien avec la préservation du secret autour de la maladie. Alors, comme conséquence, il y a un risque de survenue de grossesse compositée, de grossesse non désirée, qui peut conduire à une exclusion familiale. Alors, comme conséquence, il y a la survenue de grossesses non désirées qui peuvent conduire à une exclusion familiale ou un risque de transmission du virus à l'enfant par manque d'accompagnement social et médical. Alors, pour conclure, au Sénégal, il existe peu de réponses adaptées aux besoins des adolescents. Les adolescentes VIH+, sont confrontées au silence imposé par le VIH et au déni de leur sexualité. Une approche individualisée devrait être promue, centrée sur les besoins des adolescents. Et l'accès confidentiel aux contraceptifs est une priorité pour que ces adolescents vivent leur vie sexuelle sans stress et dans la sécurité. Pour plus d'informations, je vous invite à visiter le poster PIN 27 dans la catégorie femmes et VIH ou bien à joindre le lien de l'article. Je vous remercie.
Good afternoon, everyone. My name is Namukale Nanyangwe. I'm a site connect under the DREAMS initiative. I'm presenting an abstract on the risks and vulnerabilities among adolescent girls and young women accessing HIV prevention services at DREAMS centers in Zambia. I have no conflicts of interest to declare at this point in time, but just to note that the findings of this report do not represent the official standing of CDC and other funding institutions. That is our outline. Adolescent girls and young women in Zambia are experiencing low socioeconomic conditions, which increase their vulnerability to HIV infection. As a result, these girls have twice a higher prevalence of HIV compared to their male counterparts of the same age in the same setting. 11.1% of the HIV prevalence is accounted for by adults aged between 15 to 49 years in Zambia. So our study population was adolescent girls aged between 10 to 24 years over a period of October 2020 to March 2022. So we mobilized these girls from the community and sensitized them on what the DREAMS initiative was all about, and also obtained consent from them to participate in the program. We later took them through a standardized screening tool as well as a risk assessment, which helped us understand their vulnerabilities and eligibility to being enrolled into the DREAMS program. What you're seeing in the corner over there is a picture of a mentor obtaining consent in the community. So among the risks and vulnerabilities that were isolated, the results show that there was sexual activity, orphanhood, GBV, transactional sex, motherhood, or pregnancy. And as we can see, across all age bands, sexual activity is present. But with particular interest is the ages of 10 to 14, where we see 1% of them that actually reported having experienced transactional sex. And 0.2% of them were either mothers or pregnant at the time. And as a result, sexual debut in Zambia has been reduced to the age of 10. Within this particular age group, the highest vulnerability was orphanhood, followed by GBV, though GBV was the lowest represented vulnerability between the ages of 20 to 24. AGYWs in Zambia are experiencing multiple overlapping sexual and social vulnerabilities, as we've seen in the previous slides, and as a result, structured sexual reproductive health and HIV preventive services such as DREAMS are required to reduce the HIV risk and avert new infections. I would like to acknowledge the Ministry of Health Zambia, PEPFAR, CDC, University of Maryland, CHEB Zambia, Amsterdam Institute for Global Health and Development, community members, and adolescent girls and young women. If you'd like to get more information on what DREAMS is doing for adolescent girls in Zambia, please pass by Poster 28 and we'll discuss further. Thank you very much.